Bismillah ar-Rahman ar-Rahim. Please talk, Dr. Hay.
Okay, Bismillah ar-Rahman ar-Rahim. Hello, everybody. My name is Hani Al-Zahabi. I am the chairman of Anesthesia, Intensive Care and Pain Management Department at Ain Shams University. And I'm delighted to welcome all of you in this webinar entitled Hot Topics in Critical Care Management of COVID-19 that is held by Ain Shams University in collaboration with the Saudi Critical Care Society. This webinar is under patronage of Dr. Mahmoud Al-Mitini, the president of Ain Shams University, Dr. Ashraf Omar, the Dean of Faculty of Medicine in Ain Shams University, and Dr. Ayman Saleh, the CEO of Ain Shams University Hospital. I am honored to ask Dr. Mahmoud Al-Mitini, the president of Ain Shams University, to give us an opening words. Dr. Mahmoud.
Thank you, Hani. And thank you all for participating in this very important webinar. I'm really very grateful for you all, the Ain Shams Department of Anesthesia and Intensive Care, and the Saudi associations that just went through the program. It's really very rich program. Participants from Keck Medical Center, which I have the privilege to visit last October, if I remember well, with Hani. And we have a lot of friends there, and from other parts in the States, from Toronto in Canada, Toronto University, and from the UK. So you really constructed a very rich program, the 3 sessions that I just went through very rapidly. Actually, the whole world has been struck by this COVID-19 pandemic for the past 3 to 4, 5 months, maybe, and no single country escaped this heavy hit, if I would say. All of us are suffering. The medical community are the frontliners, and you guys, especially the intensive care and anesthesia department, are really the frontliners, and our frontliners, our heroes, I would say. And I would like to thank you all for all what you're doing, and the challenges and sacrifice and a lot of work that you are offering for our patients around the globe at this very difficult time that we are all facing. And I hope that it will pass safely and you all stay safe for the coming period. I would, coming back to the program, you have very important, chosen 3 topics that are really very important. But I would like, if you have really time, I don't know if this time or maybe next time, to touch a little bit. You know, I'm a poor liver surgeon, so to be stuck with you, the great intensivist, we are facing problem of that. As you all know, we are suspending a lot of important surgeries. One of them is the liver transplantation. That is my specialty, especially in our country, that we're doing only living donor liver transplantation. So if you can touch at the end of this meeting, or arrange for one separate meeting of how to resume the total elective surgeries that we used to do, and is totally suspended. We suspending about 75% of our surgical activity, and we're keeping only the emergent and the urgent operations to be done, as you all know. So the precautions to be taken and the measures that we must follow. I think you, as an intensivist, with all the experience you have, you can enlighten us very widely and very efficiently about this topic. I'm sure that you're going to share with each other your insights, your experience, the learned lessons from the crisis that we are all facing. And I wish you a very successful webinar. And I'll stop here, and I'll be really honored and privileged to listen to all your talks as much as I can. You know, a surgeon staying long adhering to the intensivist is not easy. Thank you very much.
I think it's time to start our first session. Our guest speaker, the first session, I'll moderate with Dr. Sameh Salim. He is professor of anesthesia and intensive care in Ain Shams University. And the session is entitled COVID-19 Surge Preparedness and our distinguished guest speakers are Professor Dr. Mu'taz Abdurrahman, consultant of anesthetist from the Royal Manchester Children's Hospital. Hello, Dr. Mu'taz. Dr. Mu'taz, hearing me? Professor Dr. Ayman Sarwat is associate
Hello, Dr.
professor.
Hani.
Hello, Dr. Mu'taz. I'm just checking with that you're okay. Professor Dr. Ayman Sarwat, associate professor at Shams University, and Professor Arash Mu'tamad, clinical associate professor of anesthesiology and director of perioperative operation at Click School of Medicine at University of Southern California. Hello, Dr. Arash.
Hello, thank you for having me.
Hi. We'll start the first question to Dr. Mu'taz in UK. Hello, Dr. Ayman. How are you?
Hello.
Okay. My first question is to Dr. Mu'taz in UK. Being primarily a children's hospital, how would you manage to serve COVID-19 patients now?
Well, let's start with, thank you very much for inviting me to talk on this very important and interesting webinar, and we hope we can share some experience together. Obviously, I work in the Children's Hospital in Manchester, which is part of Manchester University Hospitals. These are 10 hospitals. We are the only children's hospital, so one hospital does children. And as we all know, we work in the National Health Service in the UK, which follows a stringent command and a decent kind of direction which comes from the Department of Health. Now, we have something called devolution in Manchester, so we run our hospitals. As part of the 10 hospitals in Manchester, we got direction that when the COVID started its heightening, we are going to be part of the expansion of critical care treating COVID. So we're going to see how we actually manage this. As a children's hospital, you are really needing to transform all the clinical areas into dealing with adults. And I've got a little slide here which I can share with you, if I may. Not sure if I'm sharing the screen now. Not sure if it's working. Probably it is sharing now. So in the children's hospital, you see that now, yeah? Is that all right?
No, I can't see.
Dr. Hani, can you see?
No, Dr. Mu'taz. I think you just go through it.
Okay, don't worry. Okay. Screen sharing is failed. Sorry about that. Okay, so we started obviously with transformation of the clinical areas, and the first thing we thought about is the pediatric intensive care, and getting the pediatric intensive care to serve adult patients was a bit of a challenge actually, because you laugh at that. The first thing was the beds. We did have small beds, so we have to change all the beds in intensive care to adult beds. Monitors and ventilators are the same. It's just the settings on the ventilators with the technicians, which was fine, and that was done. From a location point of view, that's fine. We went to theater, transformation of theater. We divided the theater into two areas, a COVID area and two COVID theaters, and then an area where the rest of theater for non-COVID patients would be doing the emergency work. The recovery area, because we've got a big recovery area, what we have done is transform this into a critical care area to serve adult patients as well. Again, beds, we used, for this area, we used the ventilators and the anesthetic machines. That was all done. And then after that, obviously, we started thinking of how we operate this. So hand in hand, we're starting building up the standard operating procedures. That was divided on all the consultant anesthetists, and it worked quite well. We had like 7 or 6 days to put this all together. and then the item of medical staffing, nursing staffing, training, and equipment. And if we start with the standard operating procedures, as I say, we had quite a few areas which we needed to cover. I'm not sure why. I'm trying to get the screen for you, but it's just, if you bear with me a second, and I'll just say share there, it might work. No. Okay, I'll just go back to normal screen. Can't get back even to normal screen. I'm sorry. Basic. Can you see me anyway?
Yeah,
Yes.
we see.
You can see me. Okay, I can't see anything at the moment. Sorry about that. Right. Problem here. Right. So we went from distributing and dividing the standard operating procedure on consultant anesthetists. We got about quite a few. I'm sorry, I'm having a problem here with the computer because I tried to share the screen and it's all not working for me.
But we hear you. Let's continue.
Yeah. So the standard operating procedures, the examples of which I'm sure you have actually done the same. COVID intubation, donning, doffing, PPE, personal protective equipment, and there was a big array of documents and forms which we collated from the adult intensive care as well to serve the purpose of working with adults. Once that's done, we moved on to deploying staff. And Dr. Mitani saying that surgeons more or less concentrating on surgery and, you know, this business of intensive care, which is, it's a fact. What we have done is that in the redeployment phase, surgical trainees were actually deployed to intensive care to serve in adult intensive care. And quite a few of them, a group of them, has a very nice initiative. What they said is that, and they actually thought about it and they came out with it. They said, we're going to form what we call an IV line service. So all the surgical trainees said, we're going to have a rota to free the anesthetists and the intensivists to be dedicated completely to the intensive care. Any lines, cannulas, central lines, anything outside theater, we'll be looking after that. And they actually made a rota with shift for this, which helped quite a lot. Medicine, all the medical doctors, all the medical specialties were deployed to respiratory medicine. Some of them were deployed to PED. PED is Pediatric Emergency Department, and that worked quite well to offload our colleagues in PED as well. Now back to the anesthetic department and anesthetists. Job planning. So the normal standard day for an anesthetist is they come in the morning, they do 2 lists, or a morning and an afternoon list, sometimes in the evening, and that's it on several days. That was all phased out and changed. And what we have done is we put together a rota for anesthetists, which comprised of 13 hours shift. So everybody comes to the hospital, all consultants were resident. There's no on-calls, there's nothing like you're on call from home. And for quite a few of us was quite a bit of challenge as well, challenging because it was quite a bit of time, maybe 15, 20 years for some people that they've not actually spent the night in the hospital as resident. So it was all resident on calls on 24 hours. So
how did you sorry, Dr. Mu'taz, how did you ensure safe practice while putting your workload to your teams?
Yeah, what happened is that as a group or as a department, we sat together and gave it quite a bit of thought, because the pattern of work which came out was you do like 4 days in a row and then you have 2 or 3 days off, or you do 5 days in a row, and then you have a few days off. And what we actually came to a conclusion with is that we do 3 days in a row, so 2 long days and 1 night, and then 3 days off, and then the same, and it goes round and round. So it's a shift rota. And that way, we found that if you do 2 long days, and then you have an off day, 12 hours, and then you come in the night, and then after that, you have 3 days off. It worked quite well, and all of us actually liked that pattern. Well, yeah, go on.
Is there infection rate among your healthcare providers?
Luckily and fortunately, we haven't had anybody who got infected with the virus. That doesn't mean that, you know, it's an absolute nothing going to happen. We're very careful, and I put this down to probably we're all careful with the PPE. We're all careful with the way we deal with COVID patients. But luckily, thank God, nothing so far.
Okay, great. Let me ask you a final question. About at the operational level, how does your chain of command work?
Again, for the whole hospital, the way it works is we work something called Gold, Silver, and Bronze Command. The Gold Command is mainly the Department of Health, the Ministry of Health. The Silver Command is the management at the group of the hospitals, and the Bronze Command is the command of our hospital. And the way it works is that we have a meeting of the senior leadership team twice a day. So one at 11:30, one at 3:30 p.m. The attendees for the meeting, or the people who attend the meeting, would be the chief executive of the hospital, the medical director of the hospital, and the head of the departments or their representatives. And quite often from the anesthetic and the intensivist side, you get more representatives, including HR and finance. They produce an update, or what we call the situation report, which gets fed to everybody in the hospital, delineating the number of cases we have, delineating the number of cases on ICU, what's discharged, what's increased. And also the situation of the PPE, because obviously we've managed well with the PPE, but every now and then you get told that the stock is going low, and then they replenish it again. So the PPE itself was a big item on this command. And then the command, obviously, as I say, feeds everywhere. And there is a hospital report which is launched every day by email to every single clinician, telling them exactly what's happening.
Before we move to the next speaker, I think Dr. Mitini is asking a very
I'm sorry,
legitimate question.
Yeah, I lost my screen, so if you don't mind, if you can read out things for me. Yeah.
Okay. Can you hear me?
Yeah, I can hear you.
Yeah, Dr. Mahmoud Al-Mitini is asking,
yeah,
strategically planning, at what point do you think of establishing your regular elective cases?
Yeah, what's happening, which we've kind of, because of the time, we probably didn't actually talk about, the whole hospital work in stages. So the plan, or the strategic plan, has got stage 1, 2, 3, 4, 5, and so forth. We as a children's hospital, we were in stage 4. The way it works is you escalate according to the number of patients in the intensive care. You escalate from 2 to 3 to 4. We had our hump or leak, which now we're de-escalating, we're going down. What we have done is we used to do only emergencies and urgencies. Now we're doing more of the cancer work, and we're doing more of the time-dependent work. We are hoping in the next week or 2 that we are going to start doing elective work. The way to reintroduce the elective work cannot be done suddenly. It has to be done gradually. The reason is not just only the hospital. We've got the staff, we've got the theater ready now, we've cleaned everything. So from a logistic point of view, we are ready. The only limiting factor will be the PPE, because as far as we go, we will have to wear PPE for all the patients. Now this has to be put into consideration, and that will limit the number of the patients we do, because life is changing after the COVID, obviously. The second thing will be our patients. not all the patients will be able to come to the hospital for all sorts of reasons. Some of them would not want to come to the hospital because they are fearing to get infected. Even if we convince them, and we send letters, we've sent very, very clear messages, particularly for children, because we're suffering this problem in children. Lots of parents did not want to take their children to hospital, and they did have some time critical surgery, and they come with complications. So we've sent clear messages to the public: please bring your child to the hospital. So the way it works, it'll have to be launched and put in gradually. We thinking that, you know, we're starting now operating on 2 theaters. Hopefully in the next 2 weeks, we're wanting to go for 4. Our capacity is 12 theaters plus satellite. So we're talking about 20 sites. I think, you know, gradually putting it in the whole way. The surgeons are ready, but what the surgeons are doing as well is that even for the elective ones, we can't call them urgent. We have actually rejuggled or remodulated our definition of urgency to lengthen it in a way that, you know, do you know what I mean? So the urgent cases are not just urgent. They are what the surgeon think that, yes, I need to do this operation within a month. The definition of urgency is changing. Urgent means we need to be done in a week or 2 weeks. No, we need to do it in a month, so they get priority. And then we're building up the numbers.
Yes, so thank you very much, Dr. Mu'taz. For everybody, we're accepting questions to be sent to the moderators. Hope Dr. Mu'taz will remain with us till the end of this session, and we may have some questions to answer at the end. Dr. Sameh, thank you very much. Dr. Sameh, please.
Thank you, Dr. Hani. It is my pleasure to share this webinar. We'll go to our experience now. We'll go to Dr. Ayman Sarwat. Dr. Ayman, you are hearing?
Yes, I will just start.
Okay. Welcome, Dr. Ayman. Dr. Ayman actually is the head of the ICU in Al Ubur branch of Ain Shams University Specialized Hospitals. It is a COVID hospital since almost now 4 weeks. He will give us our Egyptian experience in that issue. We'll start about the human resource, Dr. Ayman, because it is the important number in the whole formula. What about the training of the staff? You started with whether physician or nursing. What's the program you achieved in this area?
Thank you so much, Dr. Sam. Actually, since the COVID outbreak begins, we were in the front line. We began planning to have part of our university hospitals to be changed from a general hospital to a quarantine hospital. And this was really a very wise decision because it came early and we were, to an extent, more ready than others in the same country. Actually, primarily, we had a plan for a human resource because most of the people, even the consultants, know nothing about this disease in the beginning. So we started to train our staff. Primarily, we had restricted to the Ministry of Health, which says that we stay 14 days in the hospital. So we began to primarily redesign our hospital. We began primarily to move all the non-COVID patients outside. And our main goal actually was to protect the non-COVID patients in our university so that we can quarantine all the positive, PCR positive patients in one place which is completely separated from the other parts of the hospital so that we can protect our staff elsewhere in the university and we can protect our patients doing other things than COVID. And this was really good. So primarily, we had a very good training for our staff. We had a training how to, for the pathways in our hospital. All the hospital was redesigned for the pathways, for the contaminated path and the non-contaminated path. Then we had a schedule for our human resource, how many we need. And it's really so dynamic because at the beginning, things were totally different. We don't have much cases, and we didn't need much nurses and doctors. But by time we predicted that things will change, and it has been. So this dynamicity came that we had on call. We had people in the hospital and people outside the hospital.
What about the duty times? You are keeping the same rota like Dr. Mu'taz, like long days duties for physician, or just 8 hours duties in-house?
Actually, ours is totally different because we move people inside the hospital for 14 days to be locked, and they will not come outside. So this is totally different than what Dr. Mu'taz said. So primarily, we plan how many doctors, nurses, and even all the helping staff, how many we need, and then we put them inside for 14 days. We train them first. We trained everybody how to wear the PPEs, how to go in the pathways. In the absence of patients, we try to simulate everything, do checklists, and putting plans for how many resources we need, covering at least 2 months in the beginning. We had a nice plan. Yeah.
What about the ratio? You are putting like algorithmic staffing. If the number of staffing like so and so will give this type of categorization of our specialists, or just it will be related to acuity of care, or just the number? I know the number is limited nowadays. How much you are giving the staff? How many numbers caring for the staff? The minimum staff at least. Well, from physician and from the nursing. Nursing also, please give me the ratio. How you are keeping the ratio between 1-to-1 or what?
In the ICU, it's totally different than in the ward. So, but I'm totally inside everything, even the word. So I will just tell you our plan. So for the critically ill patients in the ICU, the nurses is 1-to-1. We had, for the physicians, we had 6 to 8 hours shift maximum. And we have plans for the physicians to totally have 16 hours rest during the 14 days they're staying there. So we had programs that they will eat well, sleep well, and entertain well if they're not on duty. Because up till this moment, actually, we don't have much infection between the staff. Maybe things will get different in the future. But we are taking care much that even the nurses may stay just for 6 hours. They will be 1-to-1 or maximum 1-to-2 according the patient is ventilated or not. And even the doctors, we put some kind of senior staff inside also with others that he will be the head, and then he will manage the work, and we are managing also. So we put in consideration that to decrease the exposure as much as possible, and to let all the staff has some rest and also work well to give the maximum care for the patient and the maximum safety for the staff.
Okay, what about the monitoring? Who is monitoring the staff as regard to his strict following the infection control, and there is some monitoring for them, supervisors or something?
We have day-to-day monitoring. Since this began, actually, we are all involved in such issues. So we just stay. We have a multidisciplinary meeting on daily basis, monitoring every single thing in such hospital. This multidisciplinary meeting is at a fixed time each day between the pulmonologists, consultants, critical care consultants, tropicals, and the hospital management. So we are communicating on daily basis. We're discussing every single detail in the management of the patients. We have somebody doing a resume either from inside the hospital or outside, usually from inside, to tell us everything about the patients, tell us everything about the plan of management and the daily labs, everything should be presented primarily. Then we will discuss the plan of management, and then we will discuss what we need with the hospital, the administration, usually also attending such multidisciplinary meeting. The needs change from day to day. The numbers change abruptly from day to day, and we usually need to put plans. It's also very dynamic plans, getting people from outside to give help. People from inside maybe collapsing or something like that, so we just pick them outside. Lots of plans are being put to give a maximum care for the patient and also the safety of the staff on daily basis, and even communicating with the staff hour by hour.
For safety of the staff, you are keeping like temperature monitoring for the staff, Q6 hours, Q8 hours, a plan, something like that, or not?
Thank you so much for picking such issue, Dr. Sam. Actually, in the beginning, before the 14 days, we should make sure that all our staff are free. So we do a PCR at the beginning of the 14 days to make sure. And unfortunately, yesterday, we did something like this, and we picked up one of the physicians positive from outside the hospital, and he didn't begin to work. So he just changed the plan from being a working physician to a patient. So this PCR is very important in the beginning before they just go to the 14 days work. And then on daily basis, every 6 hours, we should monitor all the staff temperature. And if any symptoms appear, things will get totally different. We will isolate and then do another PCR and make sure that everybody is okay. So we are monitoring the staff, we're monitoring the symptoms and signs, and when they finish the 14 days, another PCR should be done. If it is negative, they're allowed to go out. If positive, they will stay for another 14 days.
What you are doing with the control of PPEs? You have a problem?
Actually, this PPE problem is usually a great issue because the consumption is exceeding our plans. We have lots of patients in the ICU. We need to turn them each 6 or 8 hours from prone ventilation to supine ventilation, and we need help. So we can find that problems appear on daily basis that we
How you are solving, Ayman, this problem?
As I told you, Dr. Samah, we are on daily basis with the administration, and so we report that through the administrations, through the communication, that we have problems should be solved within hours if it is actually going out of stock. What exactly we need, and also we have direct communication with our university, Dr. Mahmoud and Dr. Ayman. We just report if we need something urgently, which could need more donations or money or something, and actually things are being solved momentarily. This is through it's now for about 5 weeks we're working. We didn't face a problem which have not been solved up to this moment.
Dr. Ayman, you told me about communications for multidisciplinary meetings for the patient and with the higher management. What about the communication with the relatives of the patients?
Well, so as not to distract the attention of the consultants and the physicians in the hospital, we left such issue and we discussed it with the administration that usually most of the relatives on daily basis, they got some kind of report or something from the administration itself. If they are doctors or something, sometimes we just allow them to communicate with the doctors from outside, because most probably if they are not patients, they are not inside.
How overcome the problem of absence of negative pressure rooms?
Yeah, this was really an issue. This was really an issue in the beginning, because when we were planning and trying to redesign our hospital, we tried to do such issue and get such filters, but it was not allowable because it will need lots of change in the air conditions and things like this. So we have isolated rooms, totally isolated, and with a window glass from outside to decrease the exposure of of our staff, even the nurses, so that the patient can be monitored well from the glass outside, and then they will just go inside, do something, and get outside to decrease their exposure. Actually, for the time being, we have 0% between our staff infection. I hope it will just continue.
Dr. Ayman, Dr. Samah, let me ask, just add one point to Dr. Ayman Tharot to elaborate, because I want him to elaborate about the daily meeting that is done with the pulmonologist and senior ICU members of our department to get more brains involved in the management of patients.
Actually, he told us, Dr. Erhani, about this issue. Please repeat, Ayman, highlight it, please.
Again, please. Can you say the question again, please, Dr. Hani?
Dr.
Just elaborate more about the
multidisciplinary meeting, MDM.
Yes, yeah. The MDM with pulmonologists.
Yeah, but we have about maybe 4 or 5 consultants, pulmonologists, and the same critical cares and tropicals also. At the beginning, most of us, it was the first time to meet, or sometimes we just heard about each other, but we don't know each other. But actually, it was really harmony teamwork after 1 or 2 days, because all what we plan for is the sake of the patients, and some of these patients are doctors, and they are our colleagues actually. So within 2 or 3 days, everybody got his own rule, either in the critical care or outside, and we just hear each other very well, and then get a plan for the treatment. So we are working in harmony, and we're not having any kind of problem actually.
Okay. Ayman, for the inter-hospital transfer, you have already a plan for any inter-hospital transfer, patients coming from Ain Shams, Khalifa al-Ma'mun, or from Demerdash?
Yes, Dr. Samah. In the beginning, we thought about such issue, and we got our ambulance prepared. I have some slides I can show you if you'd like to, about getting training and putting a checklist for transferring patients, because COVID patients positive are totally different than others. They need lots of different issues and different things. So we trained our doctors and nurses in absence of patient in the beginning, how to go get the patient, how to do the checklist, and the portable ventilators actually should be different than the conventional we had at the beginning. We bought some stuff, and we got ready just before we opened the hospital 1 week. And also for transferring the patient in the hospital to the CT, we use a certain contaminated path other than the other path. And so we planned for everything, redesigned everything, and I think it's working well up to this moment.
Okay, last question, Ayman. We are thinking the coming days that will be increased patient load. What is your plan as regards the inpatient or the ICU for increasing the patient load? What is the future plan to evacuate or to transfer?
We discussed such issue just yesterday and the day before, because in these 2 days the numbers are increasing abruptly, and we are about to fill all our beds. We have some patients, it's usually with the WHO, the COVID patients being divided into mild, moderate, severe, and critical. So the mild cases without symptoms, we're calling them a good positive. So the good positive patients, we are planning to transfer them to the Yas hospital of our university. And we found lots of help from Dr. Mahmoud and others to get our Yas hospital totally prepared, so that we will just transfer them there to get more beds for the really sick people, either moderate or severe, or even the critically ill. And most probably within 1 or 2 days, we will do this plan. The good positive patients will just be transferred to the Yas hospital, and then we can accept more patients. And we have also other plans to do other hospitals as a quarantine hospitals. As the same.
Thank you. Thank you. You are ready, Ayman. Thank you very much. Thank you. Thank you.
I think we're on time to move to our distinguished speaker, Professor Dr. Arash Mu'tamid from Keck Medicine of the University of Southern California. He will talk about the operating room and airway planning for patients with COVID-19. Dr. Motammed.
Hello, everyone. First of all, thank you so much for having me here today to present. What I'm going to do right now is share my screen with you, and hopefully you will be able to see this. Are you able to see the?
Yes, yes.
Perfect. So my name is Arash Motammed. I'm an associate professor of anesthesiology at USC. My main work on the clinical side is with the liver transplant service, and administratively, I'm the medical director for Keck perioperative operations. I've had both the fortune and misfortune of being promoted to that role only 2 weeks before COVID came to our hospital. So it's been a roller coaster ride and very steep learning curve for me. And I'm happy to share some of our institution's collective experiences with you on this. What I wanted to do was initially briefly go over our hospital and the types of patients we see and our capabilities. From there, we'll focus on how we set up our operating rooms in terms of managing both COVID and non-COVID patients. I'll follow that up with a discussion on the airway and procedure team that we created for our COVID-19 patients. And then lastly, talk about some of the challenges that I foresee both near and long term. So briefly, our hospital, the main building is called the Keck Hospital, but University of Southern California has several different sites, smaller hospitals and surgical centers. Because Keck Hospital is the main workhorse for the enterprise and is where we do most of our complicated cases and is the largest one, we designated this hospital as the one to manage our persons under investigations and our confirmed COVID-19 patients. We're a bit of a unique institution in that we do not have an emergency room, we do not have OB, and we do not have a pediatrics specialty. So we're very focused on high acuity, mainly oncologic types of patients and surgeries. We have 84 ICUs, 24 operating rooms, and prior to COVID at Keck, we did about 10,000 surgeries a year, which obviously that number has taken a big hit in the last few months. Over the past few weeks, we've had about 20 patients on average per day, between 20 to 25 of COVID-19 patients. So our volume, while it's still enough to create issues and challenges, is not as high as some of our neighboring institutions. And a lot of this has to do with the fact that we don't own an emergency room where the patients can come in directly. So paramount to deciding how we plan for our operating rooms is the availability of personal protective equipment. And the table that you see in front of you is ultimately what our institution came up with in terms of deciding what should be used in what situation. And I can tell you that even though we've come to this decision now, this took a long time and it was very challenging. And the problem in deciding what PPE is appropriate has one to do with the fact that the guidelines continue to change. So whether it's the guidelines from the CDC or various societies of surgery and anesthesia, you know, they have gone back and forth in terms of what they think is appropriate and what is not. So that was one thing to deal with. The other one, which was already mentioned by our previous speakers, is just the availability or lack of availability of PPE. There is a shortage all around. And lastly, there is just a lot of fear and anxiety amongst staff, physicians, and patients. So given the information that frequently shows up on social media, whether it be accurate information or misinformation, people take these, get anxious, and want to use the most conservative and protective approach. And sometimes that may be overdoing it for the situation. Ultimately, what we came up with, which is the table in front of you, is to be able to use PAPRs along with gowns, gloves, and eye protection for any positive COVID-19 or PUI, or for any high-risk procedure, which in anesthesia involves intubation and extubation. If the patient has tested negative, then we take that down to an N95. We have the ability right now to test every single patient that comes to our hospital, so it helps us a lot in terms of deciding what we need to do. But having said that, we also understand the limitations of the test and the rate of false negatives that you may get. So we still, for most surgeries, we still recommend the members involved to wear an N95. Lastly, if it's a very low risk, very minor procedure, you know, such as a patient going in for an MRI, then what we recommend is just a regular surgical isolation mask. Now, from that, I'll go into testing, as this goes hand in hand with what PPE would decide to use. We have currently 2 types of tests available for us. So the main one that we use, which is one for every patient who's coming in for surgery, they need to be tested within 72 hours. And that test takes about 8 to 12 hours to result. We also do have the ability to do rapid testing, which results within an hour, but we're very limited in terms of the number of test kits that we have for the rapid test. So we save that for situations that we think deem it appropriate, such as an urgent emergent case, or a transplant that's coming in, or a type A dissection that's coming in that needs to directly go to the operating room, where we can't wait the 8 hours. And currently, our lab is working on doing serology testing and validating the testing. And I believe starting this coming week, at some point this week, we'll be able to have that available as well. Upon deciding the PPE and the testing, the other portion that we needed to figure out was the pathway for these patients who are COVID-19 or PUIs to be able to go to the operating room in a way that does not contaminate the other members of the team or the other patients. Fortunately, our ORs are set up in a way where we were able to dedicate a wing of the operating rooms to these patients. We've developed a transport team that helps pick the patient up from the ICU or floor and take them to the OR. And the graph that you see in front of you, it's a little bit busy, but basically what it shows is it's a unidirectional approach to going into the operating room. Then once the surgery is done, to doff in the substerile room that's between the 2 ORs, and then donning in the next OR. So what we did was any room that was designated as a COVID operating room, the room adjacent to it, we just emptied it out and made it the donning operating room. Initially, we did this for 5 operating rooms. So we had essentially 10 operating rooms out of commission. With time, we've realized that the number of patients that are coming into the OR who are COVID-19 or PUI are really not that high. We've had about 20 patients so far in the last few weeks. So actually starting this Monday, we're dropping this down to only 2 operating rooms to be able to use the other operating rooms for other surgeries. From there, I'm going to now transition to the airway and procedure team that we created. The team involves anesthesiologists partnered with a CRNA. All the individuals who are part of this team volunteered to be part of it. For us, because the operating rooms are not as busy, we have a fair amount of anesthesiologists and CRNAs who are free and wanted to help. So this helps that role for them. What they do is, whenever they get a call about a COVID-19 patient who may be on the regular floor bed or in an ICU, they don properly, go to the bedside, they intubate or place the central line or the arterial line. We cover this from morning every single day, 7 a.m. until 7 p.m. And we've created an intubation cart and a pharmacy drug box. So everything has been made for them. So it's very easy for them to grab it and go and do the procedure that they need to do. All the members of this team have been thoroughly trained on doing proper PPE and being able to operate in a difficult circumstance. We've made videos and a lot of educational material for the members of the team so that they can be ready for this. So I'll briefly go over a few of the challenges that I see either happening right now or maybe coming down the line. Most of the processes that we put in place for managing COVID patients, the major work is done. There's still a few kinks or issues, so we're going to continue to refine those. every time we get a patient that comes through or that we have to deal with and manage, we review it afterwards to see what worked, what didn't, and figure out how we can do it better next time. One of the things that was also mentioned several times in the prior presentations is the eagerness to proceed with elective surgery. The definition of elective changes regularly as we decide what cases we think is appropriate to go or not. Up to this point, the chair of anesthesia and the chair of surgery have been keeping a close eye on every single case that has gone to the operating room. But starting this week and mainly starting next week on May 11th, we're going to go into stage 1 of bringing more patients to the operating room. We're going to do this in 3 stages in May, beginning of June, and end of June to try to increase our surgical volume. Obviously, there is a significant health and for the patients and financial impact for the hospitals and the care providers. So everyone would like to do more cases, but that kind of goes into the potential limitation of resources, whether that's PPE or that's staff taking care of COVID patients in the ICUs. One of the other challenges for us in this country is, as you guys may be aware, there's been a lot of talk about loosening social distancing orders in various cities, states, and jurisdictions. So it remains to be seen what's going to happen as they loosen those criteria, and will we be seeing a second peak? Almost all of us in healthcare are not very excited about this, but unfortunately it is happening, so we just need to be prepared for it. Lastly, one of the big issues in the US is going to be the problem with shortage of medications, mainly the ones that are being used for sedation, propofol, fentanyl, and other opioids. And this has to do, one, with the need for it in the ICUs and management of COVID patients who may be on the ventilator for a long amount of time. And next to it is the fact that we're going to be ramping up the surgery, so more of it is going to be used in the operating rooms. We're keeping very close eye on this and communicating with our pharmacy department to make sure that we have the appropriate amount of medications to continue to proceed. And lastly, what I just wanted to say was what we have experienced is there's a lot of fear, there's a lot of anxiety in everyone who's involved in healthcare, whether it's the physicians or the cleaning crew. And one thing that we have learned over time is it's very important to be adaptive to the changing environment and the resource limitations. But at the same time, we have to be flexible, we have to learn and communicate, and every single time see what we can do better. So I just put up an example of 3 pictures that we took of various members of our anesthesia team when they were planning to take part in the airway team. And you can see the first time the PPE is not all that great. There's still a fair amount of area that's exposed. The second time it got a little bit better. And the third time is, which is the way we are currently, is the most protective approach that we have for PPE for intubation. And this concludes my presentation for you, and I'm happy to take any questions or comments.
Thank you, Dr. Arash. I think from the attendees, most of the questions for Dr. Arash and Dr. Mu'taz are grouping on when was the first case of COVID entered your hospital, and they are trying to ask exactly where are you on the curve?
So as far as where we are on the curve, the most recent numbers appear to say that we are flattening the curve. For our hospital, which is a little bit unique, in the last, I would say, 2 weeks, the number has been in the 20s. The highest, it was around 25. Right now, it's at 19 and 20. So it looks like we're slowly going down on the numbers at our hospital. And as far as LA goes, it appeared to be flattening. But again, I can tell you personally, if I went outside 2 weeks ago, everyone was wearing a mask and keeping social distancing. And if I go out today, they're really not doing that as well as they did. So even though we may have flattened, I'm not sure if that's going to continue or not.
Okay, Dr. Mu'taz, are you there? Can you tell us when was the first case of COVID in Manchester, and exactly where are you now? Okay, not available. I think, thank you, Dr. Arish. I think another concern that
Hello?
people are asking, hello, Mu'taz.
Oh, yeah.
Yeah, can you ask,
Yeah,
attendees were asking about the time of the first case that entered your hospital, and probably the difficult question, where are you on the curve?
Yeah, I mean, in Manchester, I would say it's kind of mid-March. Where are we on the curve? I think the numbers we have are a little bit more in Manchester than has been said by our colleague in US. We did have up to 400, and we went up to now we're getting down and down. The latest thing in ICU that we have now is about in all critical cares in the two hospitals is roughly going around about the 20s. So the curve is not gone down as we would like to, but is paused or flattened. We still got a little bit to go. It's going on the downside. So we're expecting in the next couple of weeks it'll be a lot better. However,
Okay.
We're fearing the second wave.
Okay, thank you very much. Thanks for all. I think we are 2 minutes late. We have to start the second session. Thank you.